Good evening, everybody, and welcome to our next Zoom event of question and answers. We're delighted to have Jane Heraghty with us, who is going to talk to us about the TOF cough. And if you read the opening screen about Jane, about the fact that of what she's done, working in London, training in London, being in Bristol, Cardiff, and so on. But the last paragraph is the one I love most of all. For the last 6 years, been running tracheo-oesophageal joint clinics with the surgical colleagues to reduce the amount of appointments for parents and things like that. I think that's just wonderful that that's been going ahead. So tonight's going to be slightly different. We sent Jane all the questions, so thank you for everybody who posted them. And she's looked through them and decided to do a little bit of a presentation first. So we're going to have about 20-25 minutes, or possibly up to 30 maximum minutes, where she's going through a lot of the points raised in the questions, and then afterwards we're going to go back to the questions and make sure we've answered all the specific questions. So please don't, whilst you're speaking, if you've got a question that you've already sent us, we've got it, please don't resubmit that question, because obviously we will be covering it towards the end. So Jane, if you want to switch your camera on, and then we can welcome you to the screen. Hello, don't forget to unmute yourself. Yeah. And then I'd just like to say thank you very much on behalf of TOFs for giving up your time this evening to talk about the TOF cough and chest infections. And it's over to you.
So I'm one of the respiratory consultants at the Evelina in London. And the first few of these slides kind of are going to cover what I know absolutely all of the parents will know because you've been there, but it just feels like it's easier to start at the beginning and work through things. So children with a tracheo-oesophageal fistula. So tonight we're really just thinking about the sort of the four types. We're talking about all the children that have essentially a connection between their feeding tube and their breathing tube. And that can be in any of the various formats, but essentially any sort of connection. The other type of tracheo-oesophageal or esophageal atresia patients obviously won't have any issues, but they're your three that you will have come across. These are obviously internet pictures and these are off the TOF's website, so all available for you to see. And what we've been talking about is really looking down an airway, and this is the sort of normal anatomy of a patient. So I love the fact that this is an adult patient all sitting there nicely. All of your children, no doubt, if they've needed a bronchoscopy, will have had this done with an anaesthetic and an anaesthetist in between those two people. But we look down at airways with a long, thin tube that we can look down and record the pictures from, and we're able to look at those big branches of the airway. So when you look down at the top of the airway, you see this first picture, which will be nice cartilage rings over the top and a softer back. And then as you go down, you can see branches further down. And in the second picture, you can see those in the distance. And then when you get a bit closer, you can see two bigger branches that go off into your right and your left lung. And usually the problems with children with tracheo-oesophageal fistula happen around that lower to bottom third of your trachea before it branches off into the airways. So your children will have had a connection which will have formed these sorts of pits. And the first pit is got a nice yellow arrow pointing to what you need to see. And you can see just above that with the white arrow is the airway going off to the right and left sides, just as it was before, but it's all got a bit distorted and a bit squished. And on the second picture, you can slightly see it. Some of those holes become quite tricky to see. And on the top pictures with us two together, you can see a probe into that hole. And in the third one, there is a huge grape, you can't miss it, hole in the middle. So all of these fistulas that your children have had and have been dealt with will be some format of that. And then they will have been closed off and you often get left with a pit. And then often what we end up with is a child with tracheomalacia. So that is a floppy bit of airway. So you'll see on one side, you've got a nice round airway that should be being held open by the cartilage. And on the other side, things get a bit more squished. Now, these are just patients with malacia. They're not specific tracheo-oesophageal fistula patients, but that's what we're talking about. And that might help you understand when we're saying your child gets lots of coughing, they are coughing through something that's narrow like that. And that's why it makes a different noise in your child than in the child that's got a cough that lives down the road. And that will make them have a really loud barking cough because they're blowing and coughing through that narrow tube. So that gives you your TOF cough. And it also means that the secretions, what we call poor secretion management. So during a virus, your child will produce snot and secretions all down their airway. And what you normally do is cough and clear them up. What you can imagine in your children is they cough up to that bit where it's all a bit floppy, and then everything goes back down again. And they seem to go round a cycle with those secretions down there and don't quite clear them because they don't get them past that little narrowed bit. Now, that narrow bit can be a big long bit, or it can be just a little narrowed bit, but it essentially means the secretions stay all down there in their chest, and then your child goes on to having antibiotics when another child wouldn't. And all around this there can be feeding difficulties. So it can either be that your child didn't start to feed at the right time, that there was feeding difficulties, that you ended up with NG tubes, that things went down and got stuck, and then the child didn't feed for a period of time. And all of that, things not feeding down, means your child is a bit more at risk of aspiration. So things hovering around in your upper airway above your vocal cords can then go the wrong way, and that's aspiration. So that's when bits of food go the wrong way. And in most of you, the parents that are on this call and myself, if things go the wrong way, you cough your guts up. But actually, for a lot of children, it's happened so frequently for a lot of the time. A lot of children can have silent aspiration, which means they don't respond, they don't cough and choke and splutter. So it's a bit more tricky to know that they're aspirating things the wrong way. And for a number of the parents that I think are on this call, your child might have some other problems. So they might have heart problems or other issues with their airway generally that make things more at risk of getting chest infections and chest problems. So this is the sort of questions I would ask in clinic. Now, usually I have the past medical history, so I'll know what your child's delivery was like, whether they were born early, how their TOF was picked up and managed, and if they were tricky after surgery, if they were immediately better, job done, day one, all sorted, or day two, or whether actually there were some difficulties in the past that made their breathing system. And we'll know a little bit about whether they've got heart or airway or ENT problems. And then on a clinic visit, the things I would ask about are, is your child coughing? And is that cough a dry sounding, barking, hacking cough, like a TOF cough? Or if it's sounding wet, like there are secretions down there that need to come out. So these are the sort of 60-a-day smoker kids, when you know they're not smoking, but just about everyone else thinks they must be because they've got that really wet sounding cough. I'd want to know if your child's getting short of breath, if they're at rest, or short of breath with exercise. And then each clinic visit, I'll want to know about what sort of infections your child's had and what they've needed to manage them. So have they been managed at home, or they've seen the GP and had some antibiotics, or managed without antibiotics? Did they get admitted to their local hospital? Did they get admitted to a high dependency unit locally, or and for some children, they came up to our intensive care unit, because that will change how we investigate and manage. The key bit for me is, has anyone listened to your child's chest? Because in the last couple of years, because of COVID, no one's really wanted to examine children. And so there's been a little bit of a habit towards not wanting your child to present into the GP practice and cough over everybody, and suggesting that you just take some antibiotics and off you go. The difficulty for me is trying to work out whether you actually really needed the antibiotics, or whether they were given because you'd got a cold or an upper respiratory tract infection, and actually the test was fine. And actually trying to separate those things out in a clinic appointment every few months is quite tricky. So I think it is important that your child, if they're getting recurrent chest infections or being deemed to have recurrent chest infections, that somebody actually is listening to their chest with a stethoscope and examining them and seeing what's going on. And this winter has been particularly tricky. So our winter started in June. So you'll remember in June, we sort of dumped all of the restrictions on wearing masks. And although our children were in school last winter and in nursery, often the adults around them last winter were not. They were all wearing masks and trying to avoid their friends and stay away from everyone. They didn't want to catch COVID again. So things changed for us. And so we've had a couple of summers where our winter has started in about June. We've had outbreaks of respiratory viruses, much more out of season and affecting young people, but also affecting just about everyone. And this winter, we're seeing a huge drive on patients with flu. Last winter, we saw respiratory so RSV, which is another virus, out of season in the wrong time. So things aren't quite normal, and people are getting lots more infections. And even normal children are getting lots more infections than they would normally. So it might not be that your child suddenly deteriorated. It might just be part of where we're sitting at the moment. I sometimes ask about asthma symptoms. So if there is a family history of asthma or atopy, which is sort of eczema, hay fever, food allergies, or asthma, which makes it much more likely that your child might have another diagnosis, because it's one thing saying, oh, well, they've got a TOF, so therefore all of their symptoms are related to that. But part of my job is to pick up the children that have something else going on. And the reason why they're not improving is because we're not treating with something else. One of the things I'm keen to talk about is smoking and now e-cigarette use, because anything that irritates your airway will make it a problem. So if you're asthmatic, it will make your airway a problem. But if you have already got a really reactive airway, smoke and secondhand smoke, it carries on people's clothes, it carries on their hair. Years and years ago, I used to swim, and we used to have a couple of double doors that shut the parents outside, and then a corridor and another set of double doors. You could tell when the parents were outside smoking. You could taste it in the air when you were taking big, deep breaths inside. And it makes me realise just how far that smoke carries, how much it carries on your clothes. And we've now got the sort of new phenomenon of e-cigarettes, which are hot gases of God only knows what. And we don't quite know how they will affect children's health. And they've got years to keep these lungs healthy. So generally smoking, stopping smoking, being not around any smokers is a key bit of any child with a respiratory risk. We always ask about pets. It's very rare that I suggest pets ought to be not living at home. Generally, I just say don't buy any more furry things until you kind of pull apart whether these are tracheo-oesophageal fistula issues or whether they are actual allergies to an animal. But it takes about 8 years to get cat hair out of your carpet. So the general advice is, if you're not sure, don't buy anything new until something's made a clear plan. And looking at damp at home, these are all triggers for making an asthmatic worse, but actually some of these children with tracheo-oesophageal fistula will have asthma, and therefore it's a sort of duplicate management of trying to sort out all of them. I'll ask you a little bit about whether the cough is worse at night. Asthmatic patients are traditionally worse at night, and that's because the air pressure drops. So it's nothing to do with lying flat or your pillows or any of the other things. It's just because the air pressure drops at night. It gets colder, your airways trigger in the middle of the night. For children with a tracheo-oesophageal fistula, it can be because your reflux symptoms are worse and you lie down and you're refluxing things up into your airway. So reflux might play a part. But overall, I kind of want to know how much time you're having off school or nursery. If you're coughing when you're running around, makes me think a little bit more about asthma, but they're the things that I would sort of generally be thinking about. And aspiration, so that worry about things going down into your airway when they shouldn't be going down in your airway, they should be going down your feeding tube. So things that would make me very concerned is any child who's coughing and spluttering when they're feeding, whether they breathing pattern changes. So if you drink a big bottle down through a thin tube, so sucking out of a bottle, you will breathe a little bit faster, but some children, that is much more noticeable, that they're struggling to breathe every time they're having a feed. Eye watering is another one. And when we're not sure, we get the speech and language therapist to actually do an assessment of your feeding, because they're experts at doing this. And I'll ask a little bit about any respiratory medicines you're having and how much you're using them, and regular use is generally the key. Vaccination. So this is based on UK patients, and I appreciate a lot of you tonight might not be UK residents, but your flu vaccination is standard once you're 2 years old. So you get a sniff up the nose from the GP until you're at school, and then the vaccination team come round to school. So at that point, for parents, the responsibility is to just sign the consent form and your child gets it done at school. Every year we keep extending that up. I think we're up to about year 8 or 9 at school. So the 13, 14-year-olds are being covered. The nasal vaccination is better. It's a live vaccine. It's only licensed for children because of problems with adults possibly having immune problems. So it's the best vaccine to give a child. But if you're under 2 years and you're someone who's been prone to getting infections, then it's worth asking the GP if they would do an intramuscular, so an injection type of flu vaccination. I'd recommend COVID vaccination from when you're 5. There is absolutely no evidence at the moment that COVID is any worse in a child with a tracheo-oesophageal fistula than it is in anyone else. But COVID's just one of those gifts that seems to keep giving. It changes, and what I'm slightly concerned about is we'll get a new variant that affects our younger patients more than the older patients, the converse of what we've had all the way through. So personally, I vaccinated my children. I'm going to take my gamble with the vaccine rather than an ever-changing virus. And making sure your vaccines are generally up to date. So all of your other vaccines, because a lot of them will cover a lot of the pneumonia contributors as well. So all of your vaccinations need to be up to date. We'll always ask a little bit about feeding, and usually this is the bit where I hand over to the surgeons, but we want to know what your child's feeding, what they're managing, how they're getting on with that. Have they needed to see a speech and language therapist? Are they getting things stuck, and therefore things could be causing a problem and therefore tipping over into your airway if this is happening regularly? Have they needed their esophagus to stretch? How often? And a good determinant about how you're doing overall is just your general height and weight gain. If you're breathing too fast or you're feeding badly, those will start to falter. And we ask about reflux symptoms. So usually more to do with so a lot of children will have reflux and will have a problem, but whether that's affecting your respiratory system, it will only do that for a small number of people. When I examine someone, then I would look at your height and weight, your chest wall shape, because that gives me an idea of how you're generally breathing. With children, it can be pulled out of place if you're breathing badly. I'm hoping that hasn't all come up on the screen because I've got a whole load of alerts popping up in the corner. And I'm looking generally at the breathing pattern and whether someone's respiratory rate looks normal and the way that they're breathing looks normal. In an older child, we get them to cough. Now, on a virtual link and actually in clinic as well, the one thing that makes children embarrassed is asking them to do a cough. So practicing before the clinic appointment of just getting them to do a cough would be really very useful. I've never quite realised why children go so shy when you ask them to cough, but they all do pretty much. And the examination bit. So this really needs to happen when your child is unwell. So most of my tracheo-oesophageal fistula clinics now that we run, we do virtually because there's very few patients that I actually need to examine on that particular day, that we can't get the information from bits of watching their breathing pattern. But what we do need is someone to listen to their chest when they are unwell to see whether there are secretions down there, if it seems wheezy, if any treatment's given, does it make it better or make it worse? So wheeze is just breathing through a narrow tube. So you can get that with asthma, but you can also get it with the malacia you're seeing with your patients. And so that's why it's often difficult to pull those two diagnoses apart. And I'll talk a little bit on sort of how we do that. So some children will need a chest x-ray. We get people to do peak flows, which is a sort of one-off assessment of blowing out. And we can sometimes do lung function. Now, the peak flow and the lung function are more to help try and diagnose asthma. So lung function is when you do a big blow through a computer and it measures how quick and how fast you can blow out. Now that often is lower for children with a restriction to their airway. And normally for the vast majority of the population, that would be because of asthma. But if we give salbutamol, which is an asthma reversing drug, that should get better and therefore give you a different result. But for children who've just got a floppy airway, that actually could make things worse. And that's sometimes how we use lung function to pull apart the differences. But lung function is impossible to do until you're about 5, 6 years old. It's a bit like asking your 3-year-old to go downstairs to the kitchen, take their shoes off, come on the worktop and go and open the fridge door. They might do some of those things, they might do none of them. And lung function, the difficulty with lung function is you asking children to do a series of things. Take a big breath in, blow out hard, blow out fast, and blow out as long as you can. And your brain just doesn't develop into being able to do those things until you're about 5 or 6 years old, unless you've been practicing it really a lot beforehand. And then sometimes when we can't work out what's going on, we have to do more complicated things. So we often repeat bronchoscopies and repeat scans of the chest. Now, I don't tend to do those sorts of things unless we are getting into a real sort of diagnostic dilemma. So most of my patients, I would say, would have the majority of their problems up until they're about school age. And by school age, things tend to settle down in a significant way. And it's only the children that are still running into trouble, but they're school age, that I then rethink about whether I need to reinvestigate them and look for what's going on. So they're the ones where I'm sort of scratching my head about why things haven't improved by time. You imagine that sort of narrowed airway. As you get bigger, you get stronger, your muscles get stronger, they get better at holding that airway open, and also the whole airway gets bigger. So the hole in the middle that you breathe through is all better. So usually most of the respiratory issues with chest infections and problems are in your preschool children, and things should be generally improving by the time you're school age, which is ironic because that's when you can actually do some tests to try and find out what's going on easily, but it is just the way that it is. So prevention. So as I've said, no smoking, no e-cigarettes, making sure your children are immunized, and washing your hands. So we were all a lot better when we were washing our hands and wearing masks. At least the hand washing bit can carry on, because I think it does prevent spread of a huge amount of infections. When to treat with antibiotics? Well, in theory, I think you do need a review in person. Otherwise, you could end up with the children that end up with a lot of viral infections and given antibiotics when they're not absolutely necessary. So your average child gets about 8 to 12 viruses a year. That's your average preschool age child. The difficulty with that is some of your children will then cough for about a fortnight after each one. So they've coughed for about 6 months of the year. And that probably is where some of you are feeling that you're sitting at the moment. So I want to work out if these are sort of short-term infections that are just going to go on for a few days, or whether they are actually, you know, going down and those secretions are getting infected on your chest. So they're usually virally triggered, but some of them then go on to have that prolonged sort of wet cough that does need antibiotics to clear it. So I'm concerned and think you need review if your child's finding it difficult to breathe, they're breathing fast, or respiratory distress is just a sign that they're sort of sucking in and they're breathing too hard. And then after that, I'd say if you have that sort of wet sounding cough that is at 48 hours, so 2 days in, isn't starting to get better. So if it's beginning to turn and get better, then I'm less bothered. Or if you've got a temperature that's going on for more than a couple of days. So it's okay to have a temperature. Children will have a numerous amount of viruses that will give them a temperature. But if that's not settling down at 48 hours, if their wet cough is going on for 48 hours, then you do need someone to assess them and listen to their chest and see what's going on. We were asked about preventative antibiotics. So I tend to give preventative antibiotics, and I use azithromycin, and I use it because it's once a day, which makes it slightly better, but easier to give for parents. And we use it Monday, Wednesday, and Friday. They're just random days for routine. And I tend to do that between October and March. And I do it for the children that have needed about 4 or 5 courses antibiotics in the previous winter. So you'd expect that to get better, but I wouldn't do it after sort of 1 or 2 courses, and I wouldn't do it routinely. I would only do it in those that have had intermittent antibiotic regularly. And therefore, we're trying to break that cycle. And the reason we use azithromycin, we like azithromycin as respiratory doctors, is because it's antibacterial, as you'd expect, an antibiotic. But it's also probably got some anti-inflammatory properties. So all that inflammation that you get down in your lungs with the virus, it probably helps settle that a little bit. And it may sort of have some slight antiviral properties, which makes it something that we really like. I always do a summer break. So I would stop people at usually Easter as a point to try and remember. So sort of half term from school in October, roundabout to Easter. And then we stop. And even if your child gets intermittently unwell, because there are a lot less viruses usually around over the summer, we would stop people in the summer months. That to some degree reduces the amount of resistance. So using it on this intermittent regime and having that break over the summer and using different antibiotics when you're unwell in the summer months seems to not cause a huge amount of resistance by having it all the time. And most of you will appreciate the problem months are sort of October around to March, and then you can probably manage the rest of the time. So they're my baseline things that I do. And then after that, I send you to the physiotherapy team. So, and a lot of these you can do yourself without the bailout of me sending everyone to physio. But a lot of it is trying to use activities that encourage you to take a big breath in and then breathe out for a long time. So blowing a football, blowing bubbles, tearing little bits of tissue up and making them into butterflies and seeing if your child can blow them in the air as long as possible. Folding up little pieces of paper into a caterpillar and then seeing if you blow its bum and make it walk along the desk. Blowing paint, I can just imagine the entertainment that can cause at home. Blowing musical toys or blowing bubbles from the washing up bowl. So these are all really sort of fun things that you can see that your child might actually be interested in engaging with. And then there's some other things. So bouncing on a ball or on your knee, and that's just the vibrations of sending things up. And therefore, and you also, when you're doing all of these exercises, you take bigger breaths in, and then hopefully a cough is much more likely to clear something if you've taken a bigger breath in to start with. And because you can't ask a child to take a big breath in, you know yourself, if you want to cough something up, you sort of take a big breath and then cough it. Your child doesn't know they need to do that. So we need to do other things to make them take a breath in. So bouncing on a trampoline, and my physios particularly like those that have got the nice bar attached to them so you don't fall off, or a trampoline outside, bouncy balls, but also tickling and those sorts of things will make you take bigger breaths, giggle and laugh, and possibly make you cough and clear things. And when you can get someone to play the games, getting them to do sort of 10 breaths with their blowing, and then a huff, which is a sort of noise, and then a cough if you can get someone to cough, and then going through that about 5 times. And if you can do that, and say, my physios say if you can do this sort of every day even when you're well, but I don't think that's necessary for all our patients or all the people that we see. It's only for those that are getting recurrent chest infections. The idea is if you can get into doing something regularly, when you're unwell and you've got lots of secretions down there, you can potentially get your child to do it a bit more frequently, so a couple of times a day when they're unwell. And if that's not working, then a physio is probably needed to sort of teach you physiotherapy techniques. So percussion is sort of tapping on the chest that the physios need to teach you. It actually looks quite a lot more brutal than tapping, but controlled and trained to do it. And we also use things called a baby pep, which is a little mask that you put over with which, and your child breathes out, gives them that resistance that helps open up their airways. And then they convert to being a PEP device. So these are positive expiratory pressure devices that are all little plastic devices that you breathe through on a regular basis before you would do a sort of cough and clear things. So physio should be done before food and at least an hour after you've eaten something, carried out every day, more frequently when you're unwell, but it is a bit depending on how bad and how effective your child is with things about how often you need to do it. We tend to try not to make the play things much more frequent, and we try and just reduce the burden of stuff of asking people to do stuff that they don't want to do. And then sometimes the only way to sort of differentiate and pull apart whether things are asthma or not is to actually start treatment, and it's to give some low dose asthma treatments. And I usually say 3 months. The idea is most of the medicines take about 4 to 6 weeks to start working. We're starting treatment now for the cold that might be down the line in a month's time. So what I want is a 3-month trial, which in the winter should cover some of the viruses, and see whether the treatment you actually think their child is a bit better with the treatments, or actually it's made absolutely no difference. And when you give regular treatments to try and reduce that inflammation. And as you can see, this is just a drawn picture, but asthma is that sort of inflammation in the airway, which makes your airway narrowed, which is exactly what we were looking at. And that's why when people examine children, or when they try and differentiate these two diagnoses apart, it is quite tricky to do. And sometimes you just need to bail out and give low dose treatment and see what happens. Does it make a bit of a difference? Does it improve someone? If it does, you can carry it on, or you can increase it. If it makes absolutely no difference whatsoever, then at that point I'd give up and stop, unless I'd got other evidence that made me think that they probably did have asthma.
That was brilliant, Jane. Thank you. Really informative and some really good stuff there. So what we're going to do now is we're going to go through the questions obviously our members have sent, and obviously we'll ask the questions and obviously give you time to think about the answers and things like that, and obviously try and pick up on the specifics. There's a couple of questions gone in the chat which we can try and answer as we're going along. So therefore, we've covered all the questions. So for the first question, obviously a number of members are expecting their first winter this year with their TOF baby. Why is, and obviously they're prone to respiratory illnesses, why is this year particularly worse for parents than any year?
So this is the post-COVID boom. I think we, the hospitals are fairly overwhelmed with all children struggling with respiratory viruses. And as parents, you probably picked up a cold already this winter that has been significantly worse than you would have done in previous years. As a paediatrician, I'm usually fairly immune to just about everything around. But I've already come down with something that made me feel fairly rubbish for a few weeks. I've done a million COVID tests, it's not COVID. So, and my whole team are going down in sequence with various viruses. And essentially all of our adult immunity died down with 2 years of not having any, exposure to viruses. There were no viruses when we had COVID. COVID didn't affect the children, and all the other viruses went away because we were wearing masks and we were washing our hands and we were trying to stay at least 6 feet away from the person in front of you. So we knew this winter was going to be tricky. And as a parent of a child you've literally got to take it as it goes, because you just don't know. And what you're looking for with each virus is, can your child manage? Are they feeding? Are they able to take, at least half of their milk down? Are they getting some wet nappies? Are they struggling to breathe and sucking in under their ribs, or between their ribs so you can see their rib cage? And if they are, they need a review, because yes, they are a little bit more prone than any other baby, but a baby in this winter is just as likely to be affected as any other baby. But I think it's keeping the sort of you don't know what's going to happen until it happens, and you just have to sort of see and ride the waves. If you are worried, these are the children that should have a review and get someone to actually look at them.
Okay, that's great, thank you. So when a TOF baby or child gets a chest infection and obviously require regular antibiotics, many of our parents have asked, at what point would antibiotics generally be needed? And if they were required long-term, perhaps as a prophylactic, azithromycin seems to be the name that a lot of members have mentioned about coming up with. What are the side effects, and could their child become resistant to it?
So I would say, anyone who's struggling to breathe needs a review. Someone needs to listen to their chest. But if you've got that wet cough not going away, then antibiotics probably are the right way to treat it. So I don't mind the dry coughs dragging on. Some of them do. But a wet sounding cough and it not clearing, and it sounding like that if they just coughed it up, it would go. Putting in some of those strategies that we talked about, the sort of physiotherapy techniques, the blowing, the encouraging them to cough and clear something, might get you away with it. So that's what you're trying to do as a parent, try and clear things before you get as far as needing antibiotics. But for some you will. And I wouldn't start preventative antibiotics until someone's needing about sort of 4 courses of antibiotics in a year. So if they, if we are, you have a chest infection needing antibiotics in September, October, November, then, we might cut our losses. You have to be a year to have azithromycin. It's 1-year-old treatment. And, using that sort of regime where you use it over the winter months, we don't tend to get resistant to it. So usually it works well in that sort of intermittent sort of wintertime cover when there's lots of viruses that are driving it. So when you get a virus, the cilia that waft everything out of your whole airway and make stuff come out of your nose all decide to stop working, which is particularly useful of them. So those secretions stay down there. So most of us cough and blow and clear those things up, and even small children will cough them and swallow them down. So you don't tend to produce anything out of your mouth until you're about 5 or 6. Most of your children will cough things up, swallow it down, and they'll have a stomach full of snot and rubbish and gloop, and that's just the way the system works. All sounds rather disgusting, but that is just how children function. But it's only when you kind of aren't clearing that and aren't getting better within a couple of days, then somebody doesn't listen to their chest and see what's coming on.
Okay, great, thank you. A number 3 asks, my son's had multiple chest infections, even though they've been on azithromycin antibiotics for more than a year. What course of action would you then consider if they're still getting the infections?
So I think it's that sort of starting at the top and trying to work out, is something else going on? So, Some children will have very bad malacia and will have very bad floppy airways, and we have just got to keep treating the infections as they come. And I would use azithromycin as the prevention, and I would give different antibiotics each time you're unwell, so that you are changing things around to try and cover the infection. If someone's having more infections on top of what is normal, my usual thought process is something else going on. So are they aspirating food down into their lungs, even silently, and that's causing inflammation and it's causing their chest to be worse? Is something else, have they got asthma? Do they need a treatment course of asthma to see if it's asthma that's driving this? And once we've tried all those things and we've put a physiotherapy plan in place and they're using that physiotherapy plan on a regular basis, at that point, if none of those are working, then I'd reinvestigate someone and say, right, I might have to have a look down at this airway and see what is going on. And it might depend a little bit on how sick your child's getting. So if your child gets into intensive care at the age of 3, my threshold for investigating you would be a lot lower than if they've just had antibiotics and missed school for a day. Because as parents, you'll all know you'll have different thresholds for giving antibiotics and not giving antibiotics. As parents, some, my kids never get antibiotics and are just told to man up and get on with it. But it's because I'm confident that it's virus and they can just survive. Whereas your children are more vulnerable, and therefore, and GPs won't have heard of this diagnosis or won't have met other children, so their gut instinct might be, oh, I've just got to treat it all with antibiotics. And that's the importance of someone actually listening to their chest and not just saying, oh, blogs always has antibiotics, so I must just give him more antibiotics. And whether those antibiotics were needed, which is the key bit for me to know, or whether it was just someone who was a bit worried who keeps giving them out.
Okay, that's great. Thank you. Yeah, absolutely. So some parents have asked, is there anything you could recommend apart from antibiotics to sort of help, their chest infections, their coughs and colds, rather than actually always constantly having antibiotics?
So the multi-million-pound industry that is, Lemsip, etc., none of it actually works. So all the cough mixtures do not have any effect. So cough mixtures in older patients are cough suppressant, which you don't want the patient to do. You want your child to cough the stuff up. And in younger children, all of them are just to make you feel a bit better. So paracetamol keeps your temperature down, it makes you feel better, and therefore you might actually cough and clear something up. So if you've got a child who's got a temperature and fever and is feeling rubbish, you want them to feel better so that they will do a cough and follow your instructions and try and clear something off their chest, or jump on the trampoline for a little bit and clear their chest. But everything else, all these sort of bits and everything else, there is absolutely no evidence that any of them work for any viral infection whatsoever. So if you need antibiotics because you've got a bacterial infection, nothing over the counter is going to make a blinding bit of difference. They are there to just make you feel happier. So for adults, your Lemsips and everything else, it's the paracetamol in the Lemsip works just as well as the paracetamol you could take in a tablet, but the nice lemon flavored drink just makes you feel a bit better.
Okay, great.
But there's no evidence that any of it works.
Okay, it's interesting. So we've had a few questions again about pneumonia and things like that. And one parent's asked, if their child's already had pneumonia, is it possible for them to get it again?
So pneumonia is a medical term for a chest infection. So it depends what words are being used. So to me, a chest infection is also pneumonia. They're all infection on your chest. So the terminology can be used for, we call them sort of upper respiratory tract infections, so your typical colds, and a chest infection would be a cold that's then caused a bacterial infection on your chest, and therefore a chest infection or pneumonia, and they're the same sort of thing. But for parents, a chest infection sounds a lot less severe than a pneumonia, which sounds like it's really severe. But the reality is they are all the same thing. And if you've had someone who's had a bad chest and been admitted to hospital and been admitted to a high dependency unit or an intensive care, then the chances of that happening again are higher than the child that hasn't had those things. But it just doesn't mean because you've had it once that you're definitely going to end up in hospital, because actually some of our viral infections will cause a viral pneumonia that lands you in hospital, especially in that first year of life. And it's usually under a year of life. It's called bronchiolitis. When you get a bit older, we call it either viral wheeze or, you know, a chest infection or pneumonia. They're all the sort of, it's all terminology for very similar things.
Okay, thanks. And I'm just conscious of time, so we perhaps need to just try and speed up a little bit. So a member has asked whether having a subepiglottic cyst can cause worse respiratory symptoms for their child.
So I'm going to cover these as well as the sleep one that's at the end. So anything that narrows your airway will mean that you've already got a narrowing and you multiply up with a new narrowing. So if you've got a cyst sitting in your airway, it will make your airway narrow at that point. And then you've got another bit where it's narrow, where it's floppy. And the same would be the case for having big tonsils or big adenoids. So any big blockages down a tube, if you have multiple blockages down that tube, you're more likely to have either obstructive sleep apnea or difficulty breathing. And if you're younger, you might say, well, let's just see how that goes. And if they manage colds and coughs without needing any intervention, fine. But actually, if your child's getting affected by the narrowing being there, then the first thing would be to remove the things that are already there that you can remove, and then you'll be left with the things you can't do an awful lot about.
Okay. So a mum of 14 asks, my daughter needs to clear her throat for a while when she's eating, especially when she has a drink. It feels like there's a bit of water or phlegm hanging around the lower area of her throat, and she feels like it's above her chest but below her throat, and she needs to clear it and then swallow it down again with water. This gets more pronounced before, obviously, an infection.
So we produce litres of saliva a day that we always swallow down. And just sometimes, if you've got a bit of esophageal dysmotility because you're not actually swallowing things down as well, you can just sort of leave things hovering up there, you know, a bit more. The other thing that will cause problems is if you're refluxing. So if you're refluxing things up into the back of your throat, and then that's causing inflammation and more secretions, then sometimes you do feel the need to sort of cough it and clear it and swallow it down. But it's just stuff sitting up at the top. The best advice if you're sort of doing lots of throat clearing or coughing to clear things in your throat is to just regularly drink room temperature water, because tepid water that's not hot or cold to kind of swallow things down and clear things that are there is the best way of doing it. If you keep doing those sort of harsh throat clearing, you can cause a bit of inflammation in your airway, and then that makes the inflammation worse, and then you feel the need to sort of do the throat clearing again, and you kind of go around a cycle of making things worse. So not making a big fuss out of it, just saying just take a sip of your drink is possibly the best way to manage it.
Okay, interesting that bit about hot and cold water, and you know, being tepid rather than cold.
Room temperature, it needs to sit next to you as room temperature.
Yeah, that's really interesting. So what would you suggest post-Aortopexy with regards to chest infections prevention and management without hospitalisation?
So I think all of the other things, a child who's had an aortopexy or a child who hasn't had an aortopexy, everyone's airway is a bit different. What you don't know is what you start from and what you've gone to. So how bad the malacia was when you started and where you've gone to. All of the children need to be treated exactly the same. And we would only ever do an aortopexy, which is kind of trying to pull those airways apart in the ones that are really particularly bad and they're landing themselves in hospital every time. You just hope that they're a little bit better after you've done that.
Okay, and the final question from me before I hand over to John to sort of talk about the TOF cough a little bit, and not with you, and obviously go through those questions. A new mum has asked that a baby has been recovering from infections, and the doctors don't seem to be doing much apart from nebulizing. But you answer part of that in your presentation by azithromycin can only be given from the age of 1. She's had 7 infections after being in NICU, and she's recovered from chest infections and viral like RSV in infants. So is there anything they can do, or is it just
not particularly? And I think probably the question is just making sure something else isn't going on. So is this a child that's aspirating and food's going down the wrong way? And so getting a swallow assessment and checking that's safe. And then someone who keeps landing themselves into hospital, we often have to have a look to see what their airway is doing to just make sure that something surgical isn't going to need to take place. And we mentioned an aortopexy, which is like kind of trying to hold the airway open. You would only want to do that if your child's ending up in hospital every single time your child's unwell. Otherwise, we wouldn't want to put someone through another procedure unless we absolutely have to. So there's got to be a big gain. Again, if you're getting admitted to hospital, yes, absolutely. If you're just having infections and being a bit unwell at home, then potentially, then there isn't, you know, you've kind of just got to ride it out, because it will get better with time. We've just got to get you to that time. So growing is the key bit, but we can't do much about that. It's a slow, time consuming thing getting a child to grow, but they eventually will grow out of things, you'd hope.
Okay, that's brilliant. Thank you. John, over to you.
Oh, well, good evening, everybody. And over to me for a few more questions. And good evening, Jane. Thanks very much for those responses. Can we ask and talk about the questions to do with the TOF cough specifically? And obviously, you did mention this earlier in various different ways, but just to pick up these questions particularly. First one to talk about here, many parents have asked, how should they differentiate between a TOF cough and croup or some other chest infection?
So a TOF cough is going to be just every time your child coughs, because we all cough in a day and sort of clear something out. It's just going to sound harsher and more, you know, a sort of that harsh barking noise, because you're blowing through a narrow tube. So a normal day-to-day cough, we all cough intermittently. Your child is coughing a lot at night without infections. As soon as you send them to run around in the park on a Sunday morning, they're coughing their guts up and they can't do anything. Then you just wonder if something else is going on and are they asthmatic? As I said, if you're older, you can perhaps do some lung function. And sometimes we just throw some asthma medication at them for a period of time to just say, well, look, if we give this regularly for a few months, does it make that cough better? Because a TOF cough isn't going to get better with asthma medication, but an asthmatic cough will. So, and croups are sort of slightly different. So a croup is usually it's a sudden onset, and you'll get a barking cough that lasts for a short period of time. It's usually only about 1 or 2 nights. But the times when you'd worry about that is if you're getting breathing difficulties with it, and at which point then you're going to need someone to help sort out whether a sort of acute set of steroids will help reduce down the inflammation, which is actually in your vocal cords at the top. So it sounds a little bit different.
Okay, thank you. I guess that's asked the question, the next one about asthma, but there is a question about how would you suggest that asthma should be managed alongside OA TOF?
So asthma should be used with sort of treatment plans and sort of daily monitoring. So children, what we're trying to do with a child that is asthmatic is keep them in school and able to do all the activities that they want to do. And, you know, if that takes a little bit more treatment to get there, then that's what it takes. So it is just being under the right people who understand that you're using the right treatment. Some of the asthma treatments, which reduce down inflammation in your airway, can relax the muscle, and they can therefore make your airway a bit more floppy. So it's often we give the treatments and then we're assessing what happens. So if you give salbutamol, which is your standard blue inhalers, and your child gets worse, that could be because their malacia is causing the problem and not asthma. If though you give them and your child gets better, then it's the asthma that's driving the problem. And we often don't know until we try those treatments and work it out. We have got some more kind of slightly specialized lung function tests that can sometimes help us differentiate them, but for the majority it is going to be a treatment trial and see what happens. And then the other asthma treatment that we use is called Atrovent, which is one of the less commonly used asthma treatments, but is often better for our TOF patients because it dries your secretion. So it can open your airway up. It won't cause your airway to go overly floppy, but it actually can dry the secretions a little bit. So then they become more manageable and you can cough them up. So I would say for an asthmatic alone patient, I would give salbutamol as my first line treatment for an acute exacerbation. And for a TOF patient, I would probably ask them to have Atrovent as a first line treatment to see if that helps. But
okay,
and needing to give it a go and see what happens.
That sounds good. Thank you very much. We've got a parent asking, what would you recommend as the best saline or other medication to use in a nebulizer when children have a cold or cough?
None. We never give nebulizers to children at home unless we've assessed them and worked out why they need a nebulizer and what's going on. So home bought nebulizers are a big no-no on our front. So we never give them out or suggest them unless you've had a full sort of review and a plan and that's being led by a doctor. Because sometimes for our asthmatic patients, they can disguise symptoms and make things worse.
Okay, that's a pretty good point. Thank you very much. Are there any ways we can help coughing, which appears to be from a virus or rather than an infection, without the need to resort to steroids for relief?
So if you're needing steroids for relief, that would suggest your child's got asthma or croup and not that it's because of their tracheo-oesophageal fistula, because that steroids will make no difference to that whatsoever. So you've probably got an untreated asthmatic if you're not needing to get steroids on a regular basis. And the TOF patients, it's the physio plans will help here.
Okay, that's helpful. Thank you. So we've got a mum of a 15-year-old who's asking, they're using co-amoxiclav and prednisolone. I'm probably pronounced it terribly wrong. Steroids to help manage her TOF cough. And if she's not given those, she ends up in A&E with no gaps in the coughing, struggling to catch her breath, and so on. Is there an alternative regime which you
so
might
I think she needs to have an assessment for asthma, because you're older, you should be better. So by the time you're, that older age group, she should have had someone reassess what on earth's going on, because you shouldn't have such problems, and you also shouldn't need steroids to make you better.
Okay, that's helpful. Thank you. And another parent's asked about coughing in relation to vomiting. The daughter's coughing when she's ill is triggering vomiting, which probably feeds into the respiratory issues. How can they better manage that is really the issue.
So it is not unusual for small children to cough until they throw up. There's very little ability to keep things down when they're little. They don't have gravity on their side, especially the little tiny ones. They will often cough up and clear all the mucus by coughing it up and vomiting it up. The only real way you can't really you need to manage the cough as best you can, and as we've been talking about. But I would say if your child's unwell, they need smaller amounts of liquid. They need them more frequently. So you don't, it's like Christmas dinner effect. You don't want a great big full stomach, because then the chances of when you cough and move and wiggle, everything's coming back up. So smaller amounts, more frequently. Your child needs to have a couple of wet nappies a day. But there's this sort of, you need to fluid fill people when they've got a virus. Actually, your body's quite good at retaining fluids, as long as you're not vomiting and having diarrhea profusely. Your body retains fluids when you get a virus, and we restrict fluids in hospital a lot of the time because you actually don't need as much as you think you need. So as long as you're getting some wet nappies, it's good enough.
Okay, that's good. Thank you. Someone's asking, how can we know if the cough is reflux related or related to a chest illness of some sort of chest infection?
So cough and reflux are always tricky, because if you've got a cough, you will more likely reflux, because you've got this huge big pressure being put on your diaphragm and throwing things up. And if you've got a TOF, you're likely to have reflux, because pretty much all of the patients do have some degree of issue with their tube down to their stomach. I think it's only the sort of H-type TOFs aren't so bad, but the remainder will have issues where things have been connected up and fiddled with. So I think, it comes back to doing a treatment trial. Obviously, if you're worse when you lie down and you're worse at night and you're better if you're sat up, then it's possibly reflux related. But asthma's worse at night, and lots of things are worse at night, and they're also worse at night because parents can't ask anyone what they think, and it's, everyone's shattered and exhausted and can't make the same decisions they would do during the day. If you're unsure, treating reflux and seeing if it gets better might be the only thing you can do.
That's very helpful. Well, let's just have one last question about still on TOF cough. A mummy is asking, who has a 3-year-old daughter. She's a short gaff TOF. She has a TOF cough, always worse when she has a cold, but the nighttime coughs when she has a cold are awful. Are there other things that could be tried other than the obvious?
Back to all the things I've suggested before. It pretty much is, try prevention, try the physio techniques, and try a trial of asthma treatments to see if any of those make a difference.
All right. Well, look, thank you very much. I'm going to hand back to my colleague Duncan just to wrap this up and end things off for this evening. Thank you very much for answering all those questions and for your presentation as well.
You're welcome.
Thanks.
Thanks, John. And thank you, Jane, for answering all those questions in quite succinct, in quite a short space of time. I appreciate we've got quite a few questions in the Q&A, but we've probably run out of time a little bit to answer all of them. But we have got sort of 3-4 minutes left. So how do you fancy quick fire rapid questions?
Yeah, go for it.
Let's go for it. Okay, so will Vicks or Olbas Oil help or make a difference?
So Olbas Oil, no. There is some very marginal evidence that Vicks on your chest can stop you coughing, but I think that's in other normal population children who've got a viral cold, not this group of patients. Essentially, they're all homeopathy. None of them actually work. But if it makes your child feel better, it's not a bad thing either, because half of being unwell is about making you feel better.
Okay, great, thanks. So an 8-month-old has upper respiratory infection at the moment. They had the chest listened to yesterday and it was all clear, but the cough is very wet. At which point do they need antibiotics?
So I'd give it another, so if somebody's listened to their chest and it's all fine, I'd give them another couple of days. And if it's still sounding wet, then they need examining again. So it might be something you have to kind of go through that cycle. If it's a dry cough, it might go on for a while. You can have a cough for about 6 weeks after a standard virus. Anybody can, who's a child. But for a little person, if it's sounding wet and you're a couple of days in and they're not getting better, then get them listened to again. So it's that repetitive, repeating, things haven't got better, therefore I need a further review.
Okay, and another person's asked that their son's refused azithromycin because of its taste. Is there a surefire way to mask the taste or anything else they could do?
So no is the honest answer. Some children absolutely do refuse things. Star charts in small children are highly effective, much more highly effective than you'd actually think they are. So making a star chart that if he does this, then there has to be a win. And those wins don't need to be financial. They can be mum or dad will watch the Peppa Pig movie and not move and not go and do something else, because that's what they want at the end of the week. So you have to kind of write your star chart. If you take these 6 doses at the end of the week, we will go to the park where you want to go. I will sit and watch that sodding film that you didn't really want to watch, and I won't look at my phone. But you have to win. They have to find a win that your child wants and do a star chart. And that is much more effective than trying to disguise it in something, because they're bright little souls. They can spot that it's in there and just spit it at you. And then you don't know whether it's in or out or where it is. So you're better with the bribery of getting something, the child getting a win that they want.
Okay. If damage has been occurred prior to school age, can it be reversed sort of by having sustained periods of chest-free infections?
Yeah, I mean, it takes a lot to actually get damaged lungs. And in my experience, unless you've had lots of hospital admissions with chest infections, your lungs grow. Your lungs grow quite a lot up until you're about 7 years old, and then they grow a little bit up through most of your childhood. You have miles of spare lung, it's fine. So even little bits of damaged lung will do, you could run the marathon on one lung, completely fine. But it's just about making sure that you've not got somebody who's got ongoing infection or ongoing aspiration. We will keep having a problem, and therefore, if that's not being addressed, those issues will continue.
Okay. Another parent's asked, because their daughter's 15-year-old and she keeps taking co-amoxiclav and prednisolone.
I think we covered that one. That was one of the other questions I answered. My question would be, as your child got asthma, if they're needing prednisolone, which is a steroid, there's inflammation in their chest. And if there's inflammation in their chest, you'd question why, because that is not to do with their tracheo-oesophageal fistula repair.
Okay, that's great.
Another diagnosis going on.
Okay, that's great. Thank you. So, Jane, thank you for your time. Obviously, thank you to everybody for submitting their questions and obviously joining us tonight on our Zoom, and John, obviously, for hosting in the office, for obviously organising everything for us. Hopefully, we've tried to answer everybody's questions and they've found it thoroughly informative, because I certainly have. And again, I've learned something new tonight myself, which I think is wonderful, because I love learning that sort of answers from things. So thank you to everybody for their time and obviously joining us. Hopefully you'll look at our website and have a look at what else we've got going on. And Jane, hopefully sometime next year we can invite you back again and we can do another session of this, and we can answer a lot more questions for people. Hopefully people who have had their questionnaire now in their inbox. So please do fill it in, because it will help us to sort of plan events for next year. So thank you all and have a good night.